Excellent. I'm glad to hear that. So we're back now for track 2 of our lunchtime speakers, and we've got Dr. Marc Lockhart, who is going to be talking to us about mental health, the state of mental health in the Cayman Islands. Dr. Lockhart is a psychiatrist in Georgetown, Grand Cayman. He received his doctorate of medicine from UTESA Medical College in Santo Domingo, Dominican Republic, and did his adult psychiatry residency at Wayne State University, Detroit Medical Center in Detroit, Michigan. He's been a practicing psychiatrist in the Cayman Islands for more than 15 years, and he currently serves as the Director of Inpatient Psychiatry and Behavioral Health at the Health Services Authority, where he also manages clinical duties for forensics, or prisons, and Spanish language services. He's the Medical Director of Behavioral Health Associates Cayman, a comprehensive outpatient behavioral health facility in Georgetown, Grand Cayman, and he's also a member of the National Drug Council and served as the former Deputy Chairman of the Health Practice Commission. He's currently the Chairman of the Mental Health Commission, and he's been focused on the past several years on developing a modern mental health law together with a long-term psychiatric facility. His work has been in concert with the Mental Health Task Force and resulted in the finalization of a new mental health law in 2013, which led to the formation of the Mental Health Commission, of which he was its first ever chair. He also received the honor of Emerging Pioneer in January this year at Heroes Day, which was presented to him for his significant contribution to the development of healthcare service in the Cayman Islands. His areas of special interest and clinical focus include emergency psychiatry, psychopharmacology, and mood disorders, and he continues to mentor the disadvantaged and is confidant to countless others. Ladies and gentlemen, please join me in welcoming Dr. Marc Lockhart.
Thank you very much. I thought you were introducing Donald Trump or something. So. No, I take that back. Thanks for coming. I appreciate the turnout, and I'd like to say I stand here representing two groups that mean a lot to me. And the first group are the patients that we treat and those without a voice that need to be heard and need to be taken care of. And the second group, many of you are in the audience, are those in behavioral health in the Cayman Islands that have done a tremendous job over many years with minimal resources to fight for it. I want this to be interactive. I want this to be one of the more enjoyable discussions, and I'm not criticizing any other discussion, but mental health issues permeate our society and cross all aspects of what we do and who we are. So I want feedback. I want questions at the end, so I'm going to try to go as fast as I can to allow that. Remember, there's no such thing as a bad question, and you have to remember with psychiatrists, we're the ones that listen the most when you don't make sense. Our outline today, we're going to do a little introduction and background about the Mental Health Commission in particular, the path to legislation, a little bit about the WHO aims, which is an instrument I'll talk about that helped us to quantify where we are. A little bit about child and adolescent issues. We're going to touch on why we need a policy and what policy and plan means and the benefits to us. And then some possible solutions at the end, and then we can have a discussion. We want to define mental health, and we would use the WHO definition of mental health, which is not just the absence of a mental disorder or illness, but it is focusing on one's potential, their ability to cope with stress, their ability to be productive and to contribute to our economy and society. That's the definition of mental health. And if you really look at it, you'll see that it again crosses over into all aspects of what we do. And it also then points to what we are going to be recommending from a treatment standpoint in terms of what we need to do to fix our system. The Mental Health Commission, again, I'd like to acknowledge them. The co-chairs are Dr. Taylor Burrows, who was just recently nominated as one of the YCLA finalists. And I'd like to just point out the tremendous assistance and work that she's done as co-chair, along with our other deputy co-chair, Ms. Oliver Watler. And I'd like to also point out Ms. Julene Banks, who I would also consider one of our acting co-chairs in terms of the dedication and work she's done. The other members of our team are Ms. Faylene Ebanks-Saku, Pastor Dale Forbes, Ms. Kimberly Voden, Dr. Inoka Richens, and Ms. Vanessa Gilman. Ms. Janet Flynn acts as our recording secretary, and she's a senior policy advisor in the Ministry of Health. We have a solid team of people that dedicate a lot of their time and energy towards bettering our society, and I think it's important to mention that. We hear enough criticisms about what we should be doing or not doing, or what commissions or different panels and so forth do and don't do. But it's important to point out that these are people that are dedicating their time and energy and doing it without any compensation or looking for that, but for the benefit of our community. The Mental Health Commission was formed as part of the Mental Health Law, which was tabled in the Legislative Assembly in May of 2013, after many years of work. The commission was actually named in December of 2013, and we did not have our first meeting until January of 2014. So in less than 2 years, you'll be hearing about many of the things that we've done and the things that we're trying to do. I feel, and I know I'm a bit biased, but I feel that there's been a lot of work and dedication to date. This work is going to be ongoing, and as you'd hear, we have some interesting and innovative type recommendations that are coming up. Now, the genesis and the background of the Mental Health Commission started many, many years earlier. And it started, of course, with discussions and with us recognizing problems in our community from way back. But the first formalized meeting of mental health practitioners in the Cayman Islands to actually focus on how we can change things was held in 2009, in May of 2009, when we had between 40 to 50 practitioners that met at the Health Services Authority for approximately 2 days. There were lots of discussions. We had a PAHO facilitator with us, and the conclusions of those meetings were 3 major areas: that we needed improvement in the law, we needed to get some statistics to know what we were dealing with, what were the numbers, where are the problems and the issues that we had to address, and how we should put it in a priority. And third and not least was education. At that time, we felt that there was still a lot of misunderstandings, a lot of myths, and the stigma was still very strong regarding mental health in terms of the interventions that were required and what we were seeing and facing as a population. Prior to that meeting, though, as I said, there were many discussions earlier on in the early 2000s and before about what was needed to be done from a mental health standpoint for our country. And that was even before the hospital was finalized, the new hospital that we have at Georgetown, and before there was any mental health beds. In 2000, 2001, the Ministry of Health at that time had contracted 2 specialists to come from the UK, one being an attorney, the other was a psychiatrist, to analyze our mental health system, to look at the flaws, the pluses, and to see how we could move forward into the 21st century. That was done in 2001, and it was called the Bradley and Palmer Report. And basically, they came down with the conclusions that we had a lot of work to do. They addressed the needed changes in our law. The law was very outdated at that time. At that time, it was the 1979 revision of the mental health law, which had very archaic terms in terms of describing patients and clients. Terms such as unsound mind were used to describe psychiatric ailments. The concept of a nearest relative wasn't developed, and that means having somebody to advocate and speak for our patients, especially when they're in critical moments and cannot speak for themselves. The power to detain someone against their will was not clearly expressed in the law, and it didn't have enough safety valves or ways of appeal and protection of human rights. So many issues were brought up, not the least of which I see Mr. Levis sitting here, was the inadequate conditions in the prison and the numbers of the mentally ill that were kept in prisons. In 2001, at the time of this report, there were no inpatient beds. There was not one psychiatric bed in the Cayman Islands at that point. And that meant that people who were going through serious, challenging psychiatric issues that may have made them a bit aggressive or violent or difficult to manage were kept in the central police station lockup. And this was routinely done. We tried at times to keep patients on the medical ward, but sometimes they would wander away and it was difficult. So you can imagine how painful and difficult that was to our patients and to those of us that treated patients and had to go into the lockup and treat your patient like they were a prisoner. We're talking about just 15 years ago. So what we did then was to realize we had to make some changes, and the changes need to be done rapidly. It's important to note also that this is not a political issue. I have worked with every single government over the last 15 years, and I've felt a strong commitment from every single one of those. From Minister Eden in 2009, Minister Scotland, who is also here, Minister Bodden, and now the Premier and current Minister. There has been a commitment. Now I'm seeing an increased drive and realization because of many factors that we're going to talk about. But it's important to note that the genesis behind the new law, behind what we're doing, is something that all of us in our community need to take hold of, to stand up and to discuss. This is not a political football. Three features of a good law, as per the World Health Organization, is that the mental health law should be used only in exceptional circumstances. So let me quickly clarify. When we're talking about a mental health law, we're talking about how to treat someone that, because of their illness, is a threat to themselves or others and lacks the insight and understanding that they require treatment. This is somebody that, no matter how much you talk to them and explain to them what their issues are or what they need help with, they don't have the rational understanding to be able to understand that and to conceptualize that. And there are times when their behavior puts them at serious risk or puts others at risk. The only avenue we have left is to use the law to be able to detain that person, take them to a place of safety, and where they can be examined and treated by a physician and a psychiatrist. Because of the detention aspect of the law, then, we need to keep checks and balances, and we need to be very careful of what we're doing. So mental health law should be used only in exceptional circumstances. There should be procedural mechanisms to check that law. And when we say procedural mechanisms, if I feel somebody needs to be detained, there should be another opinion if that person so chooses, or if their nearest relative feels that it's being done so unjustly. There should be a right of appeal, that even after the decision is made and the person is placed against their will in a treatment setting, there should be a way for them to appeal that. And also, there should be protection of their human rights throughout this process. I feel, and I think many others do, especially after looking at our law, that we do now have just such a law in the Cayman Islands. We have a very updated and probably one of the most updated laws in the world at this point in terms of addressing those issues. It's important to note, though, that laws only declare rights, as Martin Luther King said. It does not deliver them. That's up to us. That's up to all of us as a community to make sure that that continues. The context of legislation, as I said, why we need laws and a mental health law is because those with serious mental illnesses, as I said, at times are marginalized, are victimized, are stigmatized. Unfortunately, driving here today, I saw about 3 different people on West Bay Road that I know for sure have chronic mental illnesses that are walking up and down on the road. These are people that are more prone to be victims than they are prone to victimize others. These are people that are left to the elements. They're left to fend for themselves many times. They have difficulty involving with others, and even when their relatives try to help them, there's a lot of difficulty. Mental disorders can also affect decision-making abilities, and safety and protection is extremely important. Again, we're not talking about the full breadth when I'm talking about mental illness and the law. There are over 300 diagnoses in the Diagnostic and Statistical Manual of Mental Disorders, which is considered to a certain extent the major diagnostic Bible, if I could use that term. And mental disorders or psychiatric disorders or psychological disorders stretch from things like stuttering, sleep disorders, all the way to chronic severe schizophrenia with drug use. So when we're talking about the law, when we're talking about detaining somebody, we're not talking about the person with a mild anxiety disorder or the person with depression that's seeking treatment voluntarily. In order, as I said, in 2009, one of the final recommendations that we had was to collect statistics. We need to know what we're dealing with. You know, it's interesting, I was watching the earlier talk, and you see where the other doctors come up and they show scans, and you see lines being pushed into veins and arteries to open it up, and they can see what's going on and see where they're pushing the lines. Why is not that the same thing in mental health? We need to know what's going on. We need to know where our patients are, how many are in the prison, how many are homeless, what the diagnoses are, how many children are in crisis. And one of the ways that we came up with getting an easy and clear picture of what's going on was to use this instrument, which is called the WHO AIMS. The WHO AIMS has been used in over 122 countries. AIMS stands for the Assessment Instrument for Mental Health Systems. And this instrument gives us quite a bit of information. The reason why countries use this tool is because, again, the methodology in terms of how it's used, it's very rapid, it's inexpensive, it's available in many languages, and it gives excellent validity. When we say it's inexpensive, we did not have to pay any amount of money to get this tool for us to use it in the Cayman Islands. And as members of PAHO, we were able to get a PAHO representative to come and assist us with this. So really, the only expenditure that we gave as a country was to put up the PAHO representative for a few days and to give our time, those of us that participated in terms of collecting the information. The WHO AIMS is able to assess the current mental health system in a country. So it's not just the numbers and statistics, as I said, but also what procedures and policies and support is in place to protect and preserve and treat those with mental illnesses in any given society. In terms of our findings, it was very important to note that we had several positives, although we know that there are many negative things. Our access to medications in the Cayman Islands was considered excellent compared to some of our neighbors and other countries. Most pharmacies have at least one type of medication in all the different psychiatric classes that we need. And in most cases, we have many more than that. The length of stay on our small inpatient unit at the hospital was 12 days, which compared to other nations is actually not that bad. We have very strong psychosocial interventions, and that's a very strong positive. When we say psychosocial, we mean anything that focuses on psychology and social type interventions for patients and clients as opposed to a biological focus. So we're not talking about electroconvulsive therapy or medications or transcranial magnetic stimulation or many other types of new treatments, but we're just talking about things like occupational therapy, music therapy, art therapy, equine therapy, things of that nature, and we are quite strong as a community. One of our challenges is to coordinate and pull everything together, and we'll touch on that in a little bit when we talk about policy. The negatives. We do not have a national plan or policy regarding mental health. The good side to that is that we are moving towards that, and actually next month, a PAHO representative will be here in the Cayman Islands, and we're going to start the process of developing a formal plan and policy and getting that organized. We have very limited child and adolescent facilities. While we do have some, the need is great for more outpatient interventions for child and adolescent issues, and we'll touch on that in a minute. And another weak area is that we only have 17% of the total of our, I keep hitting this for some reason, it gets in the way. 17% of all the outpatient facilities have mobile type teams, meaning practitioners that actually go into the community, go into homes, visit clients and patients where they are, rather than expecting them to come for an appointment. Why is that important? Well, if we're dealing or treating people that, as I said, that there is a subset of patients with serious mental illness that have difficulty in terms of even understanding that they have an illness, it's going to be very difficult for them to keep a 3 o'clock appointment in Georgetown with their psychiatrist or their therapist. And we realize that in mental health, outreach type teams are extremely important, and that's something that we're going to have to focus on. Just to show you, I didn't want to clutter you too much with graphs. I wanted this to be more of a discussion, but just to highlight a few of the findings in the WHO aims. This graph represents the total percentage of children and adolescents. So this is everyone 17 and under. That were treated in all mental health facilities among all users. So these are outpatient facilities mostly, and including our 8-bed unit at the Health Services Authority. You can see that the total number, 3% of all the inpatient admissions at the HSA were children and adolescents, and they were close to 10% of outpatient visits. So a much larger percentage of our young people require the outpatient type treatments, and we're seen in the outpatient. 3% required specialized psychiatric admission. Now, what's missing from that is that there is a percentage of young people that are sent abroad, that are sent through the Department of Education, for example, that have a lot of behavioral type issues. And they require maybe some psychiatric treatment, but they require environments that they're able to have classes also, and they're environments where they're focused more on wilderness, camping, and things like that to help with the behaviors. In terms of numbers of patients totally treated in mental health facilities, there are, and this is per 100,000 now, And the reason why this was adjusted to per 100,000 is because this report is online, by the way. You can see the WHO AIMS report just by Googling WHO AIMS country report. It'll come up with a whole list, and you'll see all the different countries. You go down to the list of C, and you'll see the Cayman Islands. And to make it easy to compare us to other countries, what's done is that they calibrate the numbers on a per 100,000. So if it was per 100,000, there would have been about 7,000 people seen. But to make it clear, the actual number was over 4,000 patients, both children and adolescents and adults that were seen when the WHO survey was completed by us. And this was between 2013 and 2014. That's a big percentage. That's a pretty solid percentage. Is it much higher or higher than our neighbors or other countries? Not necessarily, but it does show, though, that with all the wonderful things that we have in our beautiful islands, we still have issues with mental illness that compare to any of the larger countries. So we have a problem that we need to address. In terms of the breakdown of diagnoses, you'll notice that on an outpatient basis, mood disorders and anxiety-type disorders were the highest. On the inpatient unit, it's interesting to note that there are 47%. Oh, did the wrong thing. On the inpatient unit, there were 47% of the inpatient admissions that were labeled as others. And those are people that had adjustment-type reactions, meaning they were going through periods of stress, maybe combined with alcohol use, or they were going through transient psychotic-type episodes. We see a lot of that related to substance use and abuse. Cannabis psychosis and things of that nature. So a lot of acute type hospital stays. We had a smaller percentage that were diagnosed with just straight schizophrenia or other types of mood disorders. Now, what that highlights to us also is the issue that we call the revolving door problem. And as far back as 1994, you can see here Davies and Drummond in the British Journal of Psychiatry highlighted a pattern that we were seeing 20 years ago. And that pattern was that a smaller percentage of very chronic, seriously ill people with serious mental health disorders were actually consuming the majority, or over 50%, of services. And a big part of that had to do with the lack of hospital beds for long-term use. So a lot of very chronic patients were coming into the hospital, spending a week, 10 days, being discharged back into their environment where the same stressors, the same challenges that they faced are still there. And then they decompensate or become ill again, and then they're back in the hospital. That highlights to us the need for two things. Number one, we need long-term treatment, and we need early intervention to prevent, as best as possible, things from getting to the point that we need to be putting patients in long-term care. I heard maybe 3 or 4 times the previous speaker said, recognition, 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 or prevention, prevention, prevention. These are the same themes that are, interestingly enough, are emerging trends in psychiatry and in medicine in general. We're finding out that if we can prevent something, if we can educate, identify, treat early, then we can really make gains on any type of illness or disorder. And I think that's a theme you're going to be hearing. That brings us then to child and adolescent issues. In a sense, those of us that work in psychiatry, psychology, and counseling and so forth are really leaning more towards being pediatricians, in a sense. we know that 50% of major psychiatric illnesses generally show some sign by age 14, 75% by age 24. So if you really look at it, even in cases where somebody presents with an initial psychiatric diagnosis at age 30 or 40, when we really look back historically, you can see that there were signs there at an earlier age. The child and adolescent brain goes through radical change and development. It's growing, it's changing, and that's when we need to target our interventions in order to prevent disruptive type behaviors and issues and illnesses from becoming consolidated. Now, there was another report I'd like to mention, and it's the PAHO Youth Survey that we may have heard of. And the PAHO Youth Survey was a survey completed in 2012 by a steering committee that included members from the Health Services Authority, included members from the Ministry of Health. They surveyed over 900 students between the ages of 15 and 19. I think the number was actually about 955. And there was an 80% response rate. And look at the findings. I mean, it's really frightening, and I just put some of them because I didn't want to overwhelm the audience with the stats. But when you see things like 50% of 15 to 19-year-olds reporting that they're being sexually active, and only half of them even saying that they use protection. 16.5% of teens have been physically abused and mistreated. The stats that have to do with sexual abuse and the initiation of sexual activity highlight serious concerns about our youth and about our community in general and what we have to do. Again, we're saying if 3/4 of psychiatric issues are identified by age 24, we need to make early interventions when we speak about youth and adolescents. So this translates then into a sequential type approach to treating these disorders. Prevention and education, intervention when it's required, and then specialized ongoing assistance to treat these disorders. And this is really what's needed, especially when we're talking about young people. It has to be, in a sense, then, a dynamic type process that's constantly ongoing. We need to educate the families and go into the homes. Remember, we spoke about the lack of mobile teams. What we're seeing, too, is that many of the young people that are the most disruptive in school and have the most problems come from homes that also have significant social problems. These are the young people, then, that when referred for treatment, don't have anyone to bring them to the hospital, to their appointments, that are the ones that miss the most appointments. They're the ones that get into the trouble the most and cause most problems generally. And again, the blame is not necessarily on them, but they don't have the supports at home, and things were not identified early on to make the right interventions. So, are we talking about spending necessarily hundreds of millions of dollars to go into every home and so forth? No. What the AIM study also showed was that we do have quite a few professionals in the Cayman Islands. And you look around, look at how many young, bright psychologists, counseling, PhDs, counselors, facilities that we do have. But it's a matter of us changing our model and realizing that it cannot all be done by government, and that there needs to be a view and a move towards more public-private type collaboration in terms of helping our young people, helping our community to move forward, and helping us all to function better. Therefore, that leads us to the need for a mental health policy. A mental health policy really is an organized set of values and principles with objectives for improving mental health overall. And when we say values, what do we want to focus on? Do we want to focus on early intervention? Do we want to focus on long-term? Are we going to focus on both? Which one first? How are we going to approach it? Are we going to involve the private sector? Is it going to be all public sector? Are we going to start to have teams across ministries, for example? As I said, the Ministry of Education sends young people abroad, which is separate from the Ministry of Health that has to send some patients abroad. Are we going to have to look when we're designing a mental health policy on how to join those two objectives? And I think we're going to have to. We need a mental health policy because, as I said, it provides a general blueprint. It gives a priority to mental health issues. It helps to develop and coordinate systems so that we don't waste money and we don't waste our resources. And we target those that need treatment and help the most at the earliest possible time. A plan and a program is more specific to actually targeting what we identify. For example, we may say we need to amplify our mobile team, so we need to design and find out which professionals we have available that can be part of teams like that. Target the areas or the districts that we want to go into. Use the schools. That's another resource that we're finding out that is very valuable, especially in treating children. We have to remember that in the same way that we as adults have been having talks, and I remember the conference, it might have been last year or the year before, that focused on workplace wellness and improving our health and our functioning in our workplaces where we spend a large part of our life. The same thing is applicable to young people in terms of using schools. That's where most young people spend most of their time, and we're missing that. And when I say we, I'm not beating up on us here in the Cayman Islands. I'm saying we as professionals, we're now realizing, and it's starting to grow in North America and in the UK, that the school is a great magnet source for treatment from many aspects. We can beef up the support network that we have in schools so that we can have better identification, better referrals, and start and initiate treatment there. So that's something else that we're going to be looking at and talking about. Now, the benefits overall to our community from the law, from mental health policy, is that it provides integration into the community. Those of us that have serious mental illnesses, or those of us that even have moderate illnesses that affect our ability to function, once we have the proper treatment protocols, it helps us to get back into the community. It improves the overall provision of services. It improves collaboration. We use the term a lot, but we need to fine-tune and make sure that the collaboration is not just a term, but that it's workable. It empowers families and caregivers. So the changes in the law has started the process. The upcoming focus on developing our policies and plans are going to continue that process. And that all feeds into the emerging trends that we're talking about. Early intervention, low-dose treatment on medications, having and recognizing that a long-term mental health facility is required, and the realization that purpose is extremely important to our functioning, are all emerging trends in mental health. And it's so funny because it seems like the pendulum has swung completely back in that 20 years ago, 30 years ago, the thrust was on, from a psychiatric perspective, that we had a lot of wonderful medications. When I trained, the goal was to use different medications, maximize the dose. The person isn't responding, go higher, add another medication. We have a lot of new meds that were coming out, early 90s and so forth, and that was a heavy focus. And even before, medications could solve the problems. We've now realized that medications are one slice of the pie. That early recognition and treatment is better, and that early recognition and treatment when medications are required should really be initiated with very low-dose medications. We're now realizing, and this could be another talk, that a lot of the side effects and complications of a lot of the medications that we prescribe. We heard doctors speak about diabetes earlier, and some of our medications can lead to things like that. So if we're going to recognize things early and start treatment, we need to be very careful and go at a very low dose. The advances in technology, we all have cell phones in here. Every single person, I'm sure, has a cell phone. We have iPads. We can communicate by Skype and so forth. All those wonderful advances are also helping us all in medicine, and especially in psychiatry, for us to be able to pinpoint and target areas of the brain that are affected. That can also help us with earlier recognition of certain disorders. It's helping us with treatment interventions. It's helping us to differentiate diagnoses. So this is all another area of emerging trends. And one major area is the recognition that we're now seeing of purpose-driven activity. That all of us, when we have something deep in our hearts or in our soul that we feel passionate about, that we want to achieve, that gets us going, that pushes us, that keeps us alive, that helps to counteract depression and anxiety. And we're realizing that medications, even therapy alone, is not enough. We need to add and really broaden our toolbox in terms of involving the other types of therapy, music therapy, equine therapy, the early intervention autism type work that's being done by some centers here. Counseling in general, the different types of therapies like cognitive behavioral therapy and dialectical behavioral therapy, and coaching. These are all types of interventions that we find actually give a robust response to our patients and our clients when they're being treated holistically. Now, as I said, mental illness and mental health issues cross all over our society and environment. And one of the major trends that we're seeing is we do not have enough psychiatric beds. And that's been a problem now worldwide, especially in the larger countries, the United States, Canada, UK. And we're seeing that here because we've never even had a long-term psychiatric unit. We're realizing that many of the social ills, many of the problems in society have as part of the root mental health issues. So I like to say that if we talk about the fabric of our society, and we hear that term a lot, I believe that the thread that sews that fabric together is mental health. And without our mental health, there is no health. US statistics show that 30% of the chronically homeless have an acute ongoing mental health issue, and up to 60% have had some mental health issues in their lifetime. Here at home, we have no history of having any long-term hospitals. Our first psychiatric bed and hospital was built in 2003 at the government hospital, and we have 8 beds. We now have 60,000 people. I mentioned earlier the Bradley and Palmer report that was done in 2001 that spoke about how horrific things were at that point in 2001. We had 43,000 people living in the Cayman Islands in 2001. Today, we're close to 60,000 people, and we still have 8 beds. We wonder why we see people walking on the road with their bags. We wonder why there are concerns and talk about homelessness. I'm not saying that all homelessness is due to mental health issues, but a large part of it is, especially when we add substance abuse and the lack of affordable housing. The prisons are another major issue. In North America, there are about over 300,000, 356,000 people that are incarcerated with mental illnesses, and about 35,000 beds in North America for psychiatric hospitalization. So 10 times the amount of people with illnesses are kept in prisons than in psychiatric hospitals. Largest number of the mentally ill are in prisons. Second largest in North America are homeless. The third largest are in hospitals. What's wrong with that? It should be the other way around. The sad thing about it is that we mirror that. Right now, the largest number of people in any institution on this island with a mental diagnosis are kept at Northwood. That shouldn't be the case. A therapeutic community farm residence. That's what many of us are pushing. The benefits for this type of facility is that it can provide culturally sensitive, state-of-the-art care. It can foster work readiness skills. It will use the psychosocial interventions that I spoke about. It fosters independence. And it gives a sense of purpose. And it's not a cement-type, large, lock-away facility. But patients in a facility like this would work on a farm and garden. You'd have different woodworking teams. You would have a team of patients that work with the animals. You'd have a bakery. We could have volunteers come in. It would help to give culturally sensitive type health care right here in the Cayman Islands. We have the weather. We have sun for over 300 days a year. We have chickens running around that we can collect. We can get wonderful eggs from them. We can have organic type farming. And you can imagine the sense of purpose that things like that would bring to our very chronically ill. It can be done here. And not only can it not be done, but we can set an example. There are not that many facilities that do this right now. There are a few in the United States. There are a few in Canada. There are several in Europe. We can, again, like we've done before, set a path here in the Cayman Islands in the same way we did in the financial services industry. We can join on and continue with the medical tourism industry in terms of having a center like this of excellence that would take care of our own first, but be able to help others and maybe give benefits all over. And the benefits are going to be reduction in cost to the government, helping with human rights issues, bringing in the process of getting some of the homelessness off the street, and bringing back probably about 15 Caymanians that have been living in exile because of their diagnosis. We have people in Jamaica, we have people overseas. I just spoke to our mother right now, and I'm not criticizing the care. We graciously appreciate that care because we don't have it here. But we cannot set a model that defines our caring for others by sending them overseas. That's not right, and that's not going to continue. Any questions? Thank you. Thank you, by the way.
We do have a few minutes for questions, if there's any in the audience. Just put your hand up nice and high so we can bring you a microphone. I see one here and a lady standing over here. Put your hand up nice and high so we can find you. I think Dr. Lee is going to get there first. Okay, we'll start over here.
Thank you. Dr. Lockhart, are you able to tell us in that Ames report if there's a breakdown on the causes of why children had so many problems with mental health issues?
That's an excellent question. No, the survey was really just looking at the picture in terms of what we have available and what the diagnoses are. In terms of digging deeper to the causes, the study doesn't actually identify that, but we do know what many of the causes are. As I said, we've had a tremendous growth. From 2000 to now, our population has gone up by over 20,000 people. We've had a world economic recession, and those things we are not immune to. So family separations, the breakup of families, the lack of responsibility, issues with our schools, other social issues have all contributed. The rise in the use of substances. Actually, drug use is the biggest propellant to serious mental illness and decomposition than any other thing. If we could point out one thing that creates the biggest amount of problems in our society, it's illicit drug use, and even some of the legal drug use like alcohol.
Thank you. In the front?
That answered my question, because I was going to ask, on the predisposition is there, how much substance abuse is contributing to it flipping into full-blown mental illness. My other question was, and we've talked about this before, is in the policy designs that are going on, will we get a validation that people's written living wills will be upheld by the law in the future? That's not in there now.
Yeah, that's an excellent point, and we do not have a formalized living will law in the Cayman Islands, and that's something that will be brought up and discussed. We'll be having stakeholders involved in that, so that will be a topic that's brought up.
Sorry, we're just getting the mic to the next lady. And I saw one over here. Dr. Lee?
Dr. Lockhart, with your, I'm over here, over here.
Over
Oh.
With your wealth of knowledge and experience, can you tell us what is your opinion on the drive and to relax the laws on marijuana use?
Okay.
Can you tell us what your experience is? What's your opinion on that? Because we're seeing more and more of that being pushed, and I dread to think what the outcome will be.
Excellent point. That's a hot topic. It is complex. My initial understanding and response is that I am very well aware that the active ingredients in cannabis can provide treatment benefits. So that's the first point. My second point is that the active ingredients in cannabis can precipitate psychosis. My third point is we do not have enough control studies. We have virtually zero of placebo-controlled scientific studies to show the long-term effects and the risk versus benefit of use. That being said, though, I do feel that we need to have the debate as a community. We cannot isolate ourselves from this debate that's going on. We have neighboring islands that have passed laws about cannabis use, and we have North America, for example, that has changed. Another important point I'd like to highlight is that I also feel that burdening a 16 or a 17-year-old with a criminal record because they have been stopped with some cannabis and making that detrimental to their future, I think is not right. We saw the slides of the adolescent brain, and you saw that there is maturity and growth. I think we would all agree that the period in our lives when we took the most risks, when we did the most foolishness, was when we were teens, wasn't it? So listen clearly. I'm not endorsing the use. I'm not saying that young people must go and use, but I'm saying we need to look at decriminalization. We need to set up and have physicians from different areas get together, and maybe we have some type of a panel and discussion about how we're going to move forward. Where are we seeing the benefits of cannabis or THC use in terms of it for in ophthalmology? We know that it has benefits. We know that in cancer care it has some benefits, so that we can really study it properly and address it realistically.
Dr. Lockhart,
Yes, sir.
very good presentation. The one thing that I saw was missing from it is how are we going to address the financial side going forward. It's all good to have the policy and the improvements to the law and so on, but I think that the biggest constraint to people getting access to mental health care up until this point has been the financial side of it. You mentioned about government, and yeah, we know that the people that are getting treatment now, a lot of them are being paid by government. But I think the biggest constraint to others accessing that care at this point is the financial side of it. And we know health insurance, for instance, even with improvements, doesn't cover very much mental health care. So I think that needs to be part of the discussion going forward as well, in a plan and everything else that we're doing as well.
Former Minister, that is an excellent point. Seriously, the insurance companies need to be taken to task. And I'm not afraid to do so because they don't pay me anyway. It is clear. I'll tell you something. Before coming here this morning, the last patient I saw was a lady that called in crisis. She was breaking down. She was extremely emotional. She lost her job 3 months ago. She's still struggling. Her husband is the only breadwinner right now. She's had a history of depression. She's tried about 7 or 8 different medications and different therapies. The last medication that she's just been put on, she's having trouble. She went to the pharmacy after having filled it for the last 3 months, and she was just told at the pharmacy that your insurance company is not covering it. You need to pay cash before we can give it to you. She didn't have the money. She's on the medication. She's extremely depressed, bordering on suicidal thoughts. She comes in the office, so I have to figure out now how to wean her off of the med, add something else, and hope that she stays stable. The insurance companies need to realize that just because people with serious mental illness do not have a voice, there are none of us sitting in here right now with a serious mental illness. Because those that have that level of illness at this point are unable to sit here and communicate their needs and desires. And because we cannot get 1,000 of us to march on the street and to wear pink ribbons and so forth, we're not heard. And the insurance companies scratch us off the books. Now, the other thing is, investing in mental health care is investing in our communities. It's investing in all of us. If we can pay for somebody to get their medication to function well, if they get back to work, they're working, they're producing. We're not asking for millions of dollars. You get one CT scan, which I just got because of my bad back, was what, $3,000, $4,000 or something for that one scan. I sat in the machine for about 30 minutes. I see a new patient for $200 and something. All the therapists here struggle, some of us, to be able to bill our patients to survive, but yet still the insurance company doesn't want to cover it, and they say pre-existing conditions and so on. So that's one part, and I don't want to make it look like it's all the insurance companies' issue, but also public-private type ventures are also extremely important.